This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Joanne Mortimer, Director of the Women's Cancers Program at the City of Hope Comprehensive Cancer Center in Duarte, Southern California. Hi, Dr. Mortimer.
Hi, Selma.
Welcome back.
Thank you.
Last year at this time, we sat with you and you were talking to us about your imaging study, and we wanted to reconnect. Where are we a year later?
We developed this imaging agent that is basically trastuzumab, Herceptin, with a label on it, so we can use it as a PET imaging agent to identify HER2-positive breast cancer. So last year we sort of refined the technology so that when we do these PET imaging in women who have known HER2-positive breast cancer, that we identify cancer and in all places. So we proved that we had a good imaging technology and technique. This year what we did was to look at women whose cancers were by pathologic definition not HER2 positive. So women whose cancers were 1+ by immunostaining, 2+, and then we compared them to 3+. You know, one of the themes of this meeting seems to be sort of the molecular profiling of cancers, and you know, as a clinician, when you treat breast cancer, you treat it on the basis of estrogen receptor and progesterone receptor and HER2, and it turns out that, you know, there's a lot of mix as to how you measure this, and that's exactly what our data has shown us, is that women who are 1+ and 2+ actually pick up this tracer. So most breast cancer, at least to a certain degree, has HER2 receptors on it. Our next step is trying to figure out how we use this to hopefully predict response to drugs like TDM1.
Where you are in the level of your research now, where do you have to yet go? And then how does this become more widely disseminated throughout the country into a standard of care?
Right now, this agent is actually made at City of Hope. You know, if we actually are able to demonstrate that this drug allows us to predict people who would not otherwise get drugs like TDM1 and yet they work, then it won't be very hard for people to have commercially made product. I'm sure somebody would pick it up and make it because it's not all that complex. And ideally, it would be able to more, again, this personalized medicine notion, but we would be able to identify women who might otherwise not be getting drugs like TDM1, that they would be candidates for it.
So in the course of from last year to this year, your research has been further validated. Now what? Now
that we've validated it, it really is how are we going to use this clinically? Because just having an imaging agent that sees breast cancer, that doesn't really add anything, because the standard PET imaging does that right now when you use glucose as a tracer. We really need to use this to predict who benefits from HER2-directed therapy and who will not. And I think that cuts both ways. Right now our fascination is that there are women whose cancers take up this and may benefit from drugs like TDM1. And on the other side are people who probably aren't going to benefit from the drug, and to be able to identify who benefits and who's not going to benefit gives people who wouldn't get the drug the opportunity to have an effective drug, and those who are getting it with no benefit avoiding the side effect and the hassle of getting drugs like Herceptin on a every 3-week or weekly basis.
Thank you very much, Dr. Joanne Mortimer, Director of the Women's Cancers Program at the City of Hope Comprehensive Cancer Center in Duarte, Southern California.
Thank you, Selma.